Hello, everyone, and welcome to today's live broadcast, SARS-CoV-2 infection, updates on laboratory diagnosis. I'm Susie Valdez of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is brought to you by LabRoots and sponsored by Abbott Diagnostics. So let's get started. I'd like to remind everyone that this event is interactive. We encourage you to participate by submitting as many questions as you want at any time during the presentation. To do so, simply type them into the Ask a Question box and click the Send button. If you have any trouble seeing or hearing this presentation, simply click on the Support tab found at the top right of your presentation window, or report your problem by clicking on the Ask a Question box located on the far left of your screen. I'd like to now introduce our presenter, Dr. Claudio Galli, Associate Medical Director in the Infectious Disease at Abbott Diagnostics. For a complete biography of Dr. Galli, please visit the Biography tab at the top of your screen. Without further ado, Dr. Galli, you may now begin your presentation. Welcome, sir.
Good morning or good afternoon, everybody. Thanks for joining today. Our purpose is to review some aspects on serological testing for SARS-CoV-2 infection. And actually, the best way to start is to have a look at the definition that has been issued quite a few months ago by the WHO. And based on the definitions you see there, a confirmed case of SARS-CoV-2 or COVID is a case that is confirmed by laboratory testing. And this puts, of course, a huge burden on laboratories everywhere because this is a need, not just an option. So how do we deal with diagnosis? The first and foremost thing that people will look for is viral RNA. This is recommended everywhere, and it makes a lot of sense because it gives you an idea if the microorganism is indeed there. Point is that regardless of the technique that is used and the sensitivity, the yield depends a lot about the kind of samples you are using. So the deeper you go into the respiratory tract, the higher it is the likelihood to find viral RNA. And there is quite a good reason for that. When you compare the yield you get from nasopharyngeal or throat swabs with those you can take from sputum or stool, there is a clear difference in that almost 2 logs in median values are attained. In practice, what does this reflect to? Well, the more you go on over the course of the infection or disease, the least likely it is to have a positive result, especially if you are taking samples from, as usually is done by nasopharyngeal swabs. In this experience you see here, up to almost 6 weeks after the onset of symptoms, the likelihood of having a positive result after 3 weeks is very low if you're taking samples from the upper respiratory tract. And this was already well described by a review paper that appeared recently on JAMA, in which the authors pointed out at this instance, as you may see here, 2 relevant things that we may note on this summary slide. First, the infectivity starts earlier than symptoms. And this, of course, is very relevant because it justifies the rapid spread, the infection, and the high contagiousness of these infections compared to other similar ones, such as the former SARS that we did experience so many years ago. The second fact is that, indeed, the viral isolation may be attained only for a limited period of time. Actually, the first week or a little bit more. Of course, this is a scheme, does not pretend to be exhaustive on all possibilities that you will encounter in clinical practice. But what is usually done, so testing for RNA yields different results according to the source of samples, as we have seen. But regardless of that, you may note that when you reach this point, that is around 3 weeks after infection, it is even less likely than before to attain a positive result. And at the same time, antibody response to that infection appears more or less in this period. We will be more precise a little bit later. And so by coupling the RNA detection and the antibody detection, it is possible actually to help in diagnosing the infection much better than relying on PCR or RNA testing alone. And this, as we have noticed, is even recommended. Now, how may you do that? One possible solution is use this kind of assay. This comes from Abbott Diagnostics. It's an assay for specific IgG to SARS-CoV-2, and it's targeting a recombinant antigen from the nucleocapsid region of the virus. So there are several topics to deal with. Let's start with the target selection you see here. As you know, the most immunodominant regions are the spike and the nucleocapsid ones, and assays may target one or the other according to which is the preferred need. So, having selected the nucleocapsid was based on the fact that during infection, nucleocapsid antigens are usually expressed to a higher yield compared to spike, and as a consequence, the antibody response towards nucleocapsid tends to appear earlier and possibly stronger. You see here, immunocompromised patients, and here on immune competent patients, how it may happen. And you may have even a better glimpse if you look at this series of patients that have been assayed by an assay directed against the nucleocapsid or against the spike RBD domain. On the same scale of intensity of the result, you can see that the and PIgG appeared in general earlier and attained higher levels. And we have another example here. Another thing you may note is that in severe cases such as those, the response tends to be stronger, whereas in mild cases it tends to be weaker and also possibly delayed on time. And this is something we will deal with near the end of our presentation today. The other issue, of course, is establishing the positive agreement or sensitivity, if you wish, of any given assay. In the case of the targeted SARS-CoV-2 IgG, this has been done in the validation by taking a cohort of patients that have been tested in a very early phase or a little bit later, so until 2 weeks after the onset, and then after 2 weeks or more. The data you will find in the insert give these figures, but those figures do come with a confidence interval because, as you know very well, 100% will never exist in medicine or in biology. So everything should be framed into a very specific confidence interval. And we have another demonstration of that comes from real practice. When the authors of this paper checked their population, which was quite large because they took samples for more than 400 patients, and they compared the positivity rate by that assay with the time after the onset of symptoms, they basically found the same values that we have seen before with an increase over time. If you wish, quite surprisingly, they did find antibodies already in 50% of the population after just 1 week. And then when they compared the results, not just to the days after the onset, but to the first positive PCR, the yield was even higher. And this is logical because, of course, PCR testing happens after the onset of symptoms. So actually, the lag here is about 3-4 days, and this is why after 2 weeks, they've seen a complete concordance of results. So as it seems the sensitivity in the early stages is quite good, and so it will allow to increase the diagnostic yield when RNA testing is not positive or is not feasible. The other big topic to deal with, especially now when the peak of the epidemics has been reached and passed away in many countries, is specificity. Specificity and negative agreement may be looked at differently. So you may take on samples with potentially interfering conditions, which is a classic in laboratory medicine. You may take samples from other respiratory illnesses, possibly similar to the one we are dealing with, or you may take on the samples that have been collected in the pre-COVID era. And this is a true specificity because, of course, since the virus was not circulating at that time, those samples should come up negative. And this is the value that has been checked over the validation of the assay. But even in this case, we do have external evidences. First of all, in the validation process, we were not able to assess the eventual cross-reactivity to other coronaviruses because those samples are quite rare and those were not available for the internal validation. But as of now, we already have 6 different external and independent evidences that check at this, And all of those confirm that this assay does not resent from the testing by other coronaviruses. So all those, almost 60 samples, come up negative. On the other side, if you want to check the classical specificity on the pre-COVID samples, we still have the paper we have dealt with before, the first published independent evidence. And in this case, the authors did attain even a higher level of specificity. Same indication as we said before concerning sensitivity. Every value you will look at in any paper should also be accompanied by confidence interval. So in 99.6, 99.9 is more or less the same, because even if the cohort is pretty huge, this is not an absolute value. The other valuable information we get out of that is the distribution of the negative results. As you know, an assay may be more or less robust depending on how the results are distributed, and the more the negatives are far away from the threshold area, the better it is, because it will guarantee against shifts in specificity according to external variables. You see that in this experience, there were just a dozen samples, so that is 1 out of 100 of the population that were above this level, and very few that were across this critical area around the cutoff. This means that the assay is very robust, and the specificity attained would be more or less the same regardless of when you take out testing. And this is confirmed also by another evidence that is just in preprint now. This combines the detection according to the weeks after the onset, you see here on the left, and the specificity of another cohort, very similar. And you see that the distribution is the same. The specificity is 99.8%. And again, there is just one sample that is across the cutoff area, which is this dotted line. Why I'm pushing so much on specificity? This is important because in this kind of testing, we do not have a confirmation available yet. So you do have a positive result by any given assay, and that's it. You may revert to some recent recommendation from the CDC to do some orthogonal testing, that is using a very sensitive assay beforehand on the first pass, and then having a second assay to increase the predictive value. And the predictive value, indeed, depends, as you know, on the specificity and on the prevalence. So the lower the prevalence, the lower will be the predictive value, and this is an example of that. If you take into account this kind of population with an estimated pretest probability of 3%, and you use an assay that has least level of specificity, which may be considered good in diagnostics in general, well, in this case, actually, the predictive value is very low. So you have more false positives than true positives. If you increase specificity to 99%, it's definitely better, but still 1 out of 4 will be a false positive, not because the assay is not specific, but because the population has not such a huge prevalence. And if you increase that to a value that is the one actually attained or even better by the architect assay, you have this kind of positive prediction. If you want to have an actual figure, on the study I mentioned before, they did a population survey in Boise, Idaho, find this kind of prevalence very low, but since their specificity was 99.9%, then in that instance, even with a very low prevalence, the predictive value would have been almost 95%, which is very hard to attain, by the way. And this has become increasingly relevant, and the more we go on, the more we will see antibody testing in asymptomatic populations and in people that possibly did not have any link, clear epidemiological link. What about then the sequence of the appearance of biomarkers? We have seen that before in another slide. This is more schematic. It's divided for convenience in incubation, early acute, late acute, and convalescence. The sequence should be as such: viral RNA, viral antigen, if feasible, okay, a little less sensitive. Then usually you have the IgM response and then the IgG response. The difference is that this response will last much less, and we will see data on that, whereas the IgG response will peak later and stay on for a long while. How long a while, we don't know yet. hopefully it will be lasting long enough to guarantee some sort of protection, but this is still to be determined and uncertain. This is in theory. What happens in practice with the SARS-CoV-2 infection? Well, we do have data that more or less are concordant in that different observations have allowed to the conclusion that indeed the IgM and the IgG response to this infection are pretty much alike as far as the time of onset is concerned. You see here that the days relative to the positive PCR for IgM or IgG are more or less the same. Each colored line represents a patient. If you wish, we may have a more easy to look at slide here in which you see the difference is some cases that did seroconvert earlier for IgM and earlier by IgG, which may seem absurd, but it does happen in this infection, and it is not so infrequent. If you wish to have a more comprehensive picture, we may revert to this kind of evidence that has been generated on quite a huge cohort of patients. This is the IgM line that raises over time and peaks at about 90% after 3 weeks. The IgG line peaks around 100% at the same time. And if you add the IgG to the IgM response, actually the gain is minimal, if any. So you attain the same level of sensitivity. But there is still a difference, if you wish. You may note that on the dots here. So let's say that you're testing at this point, around 2 weeks, you have a maximum likelihood of finding the patient positive for IgG than for IgM. But in some instances, you may see IgM coming first. Another evidence still on a quite huge cohort brings up the same kind of results. You see here that a positive rates for IgM and IgG showed some 10% difference cumulatively. And this happened more both in RT-PCR positive and negative infections, so different phases of the disease or infection. So overall, it looks like a good assay for IgG will yield a very good sensitivity regardless of the detection of IgM. But IgM may be still relevant if you're able to discriminate the two answers and the two responses, as you will see soon. First, a thing that may happen, and indeed has been demonstrated, is that the level of reactivity to IgG and IgM may be different according to the severity of the disease. This is indeed more evident for the IgG response, especially in the early stages. You see here in this other independent experience that IgG levels attained over the first couple of weeks were definitely higher, significantly higher in patients having a more severe disease. This was not such apparent later on, and for IgM, this did not happen. So possibly, patients that are severe disease do raise a stronger IgG response to the viral infection. And over time, by the way, the persistence is quite different. We have seen that in the scheme that we proposed before getting into the details of IgM and IgG. You see here an IgG course with the levels that are still quite high. This is an arbitrary unit by another assay. So if you reach this point, that is many weeks after the onset, 56 days, you still have quite high levels. But if you go to the IgM in the same cohort, first of all, we'll note that the levels are much more variable. And second, when you reach this point, that is 56 days after the onset, almost 2 full months after, the IgM levels are usually not detectable. You have exceptions, but on average, the IgM wanes out. It is not readily detectable. So if you're able to test for both IgG and IgM, you may combine different results and get also an idea on how recent the infection has been. Another thing that people would like to do is what happens if I test during an outbreak people that maybe do not have symptoms. And this has been carried out to our attention by this recent experience, a testing carried out on an aircraft carrier by the US Navy, where they experienced an outbreak. And they did find that indeed 60% of the population, young adult population here, had reactive antibodies, and 59 of those already had neutralizing antibodies at the time of specimen collection. But 1/5 had those symptoms, And the preventive measures reduce the risk of infection. Again, the relevance of preventive measures, barrier methods, and distancing is to be continually enforced. But you see here mentioning the neutralizing antibodies, and this is another very interesting topic. I think we need a word of clarity about that. Everybody has seen papers or wrappers about neutralizing antibodies, neutralizing activity, immunity, and so forth. Let's try and sort it out. The presence of neutralizing antibodies in the majority of people here is a promising indicator of at least short-term immunity. This is very wise. At least short-term immunity. We still do not know about the long-term immunity. This is a goal. This is a target. This is what vaccine design is aimed to. But for the time being, we cannot state anything about the long-term immunity, especially just by testing for antibodies. And this is why. There is a difference between binding and neutralizing antibodies in that all assays that are in use now are testing for binding antibodies. Even if they target the spike region, the RBD domain or whatever, they will not detect the neutralizing activity, okay? They may be related, and indeed will be related to neutralizing activity, but that's it. If you want to check a neutralizing activity, you have to run viral testing. So in order to find functional ability of antibodies to prevent infection, you must revert either to virus neutralization or to microneutralization, and both techniques require viral culture, require BSL-3 level laboratories, and are quite long to be performed. An alternative may be to use a pseudovirus neutralization test with recombinant viruses, and this may be done in labs with a lower level of security. But this is different from this. What people would like to see is any degree of concordance of correlation between the binding antibody detection and the neutralization activity. And indeed, there are a few evidences on that we may share. So the point of having a correlation between ELISA ratios and neutralizing activity has been raised and demonstrated in quite a few evidences and independent papers. In this one, for example, authors were able to find a direct correlation to a high degree between reactivity to the nucleocapsid or receptor binding domain, or S antigen in general, and the 50% inhibition of viral culture. And the same at the 90% inhibition. And this may be surprising because the antibodies raised towards the nucleocapsid are not neutralizing by definition. So this just means that a strong antibody response is anyhow correlated to the neutralizing activity of that sample or that patient. And this was also demonstrated in another study and in a couple other ones. And if you wish, you may go to a direct evidence concerning the RBD assay by two different levels of testing. This has been done in a very recent paper by Finnish authors, in which they ascertain the concordance between a neutralizing activity and the positivity for IgG antibody checked by different assays. You see, we are dealing with this one in this specific case, and out of all samples that did show neutralizing activity, the assay was positive in 80%, which is higher compared to the other assays. But even more interesting, if you wish, is what we have seen in another experience that has been recently made available. This has been raised by a collaboration between the San Francisco University and Abbott R&D. And on this cohort of patients, you see on the top part of the slide, the seroconversion from different patients, immunocompetent and immune-compromised, with the time span between 4 and 26 days from the onset, and the median or 11 days. On the bottom part, you see the rates of neutralizing antibody activity assessed by pseudovirus entry inhibition, which is the third method we have mentioned earlier. And you see that the time lag is the same, and the median time is the same as well. And this has been confirmed also as far as the IgM reactivity is concerned. You see that the time lag is almost identical. It may start earlier in a few instances here. The median is the same, and of course, this is again the same. So what's the general meaning of this kind of experiment, which is up to now pretty unique? The first thing that we may observe is that indeed the neutralizing capacity of every patient may start as early as a few days after onset. This is not a fully neutralizing activity, but it is something that happens and increases over time. You see that over the time span of 3 weeks, this neutralizing activity is demonstrated in almost 100% of patients with an increasing titer. At the same time, also the levels of IgM and IgG are raising. So we are going back to the original observation in which we have hinted that a good and strong serological response by any assay, so even by a nucleocapsid targeting assay, will relate to the neutralizing activity. Then, of course, we cannot stretch it to demonstrate that neutralizing just by testing for binding antibodies, but it gives a justification on the correlation we may find in different experiments. So if you want to conclude on the different combinations you have here, assuming that you have this kind of time course in which RNA will fade away earlier, then IgM and then IgG will persist longer, you may have this different combination of results. If you test for both RNA, usually by PCR, and for IgM and IgG separately, which will allow to time better the infection, you have all the different combinations you see here. 2 of those may be looked at more carefully. This is the one, the last one is the one that will be attained the more we go on testing on a symptomatic population or doing population surveys. So more and more cases will be positive just for IgG. And then we may have also the instance in which only the IgM is positive. So this should be deemed as a recent infection with a negative PCR result by any given cause, timing, pre-analyticals, whatever. But it may also be due to a false positive IgM result. And you know that usually testing for IgM is, let's say, more delicate than testing for IgG. But here again, we do have some data to show that the prototype assay from Abbott IgM to SARS-CoV-2 that was used in this paper did show a very good specificity as well. I would say at the same level as the IgG assay we have seen before. And again, you see a good distribution and very few samples around the threshold. So this is promising in the sense of what we have seen before, that is combining testing separately for IgG and IgM. Then, if you wish, what is antibody testing useful for in general? Well, it may tell you something. It may tell you that a person has been infected in the past. We don't know how much in the past until we test separately for IgG and IgM. If both are positive, well, the infection is very recent. If the IgM is negative, IgG is positive, it is a more distant infection, at least several weeks. You have seen the graph with the IgM reactivity that appears to be not present anymore after a couple of months. But at the same time, we should be aware about what antibody testing cannot tell you. It cannot tell you if the person has recovered because it does not preclude persistent infection. The recovery is usually established by repeat testing for RNA. This is the rule of thumb as of now. It may not tell the real antibody level. We do know that there are assays that do express results in arbitrary units, but at least according to the CDC, and this makes a lot of sense to me as well, the assays at best are semi-quantitative. There is no standard unit. There is no reference. So speaking about quantitation of antibodies is a little bit too early. And at the same time, as we have seen before, we have binding antibody assays. We cannot tell it right away any kind of serology you have available now if the antibodies are really neutralizing. You need a specific neutralization assay to be performed. We may anticipate that this will not last for a long time. Eventually, we will have also assays who will detect specifically the neutralizing antibodies, but not now. Then, as a last part, I would like to present you some scenarios that may occur. If we assume that in case with symptoms or at high risk, we are testing for RNA plus serology according to the different environments, according to the different rules, you may have this combination of results. And quite obviously, if you just have a positive for RNA, this is an early stage of infection, unless the person is immunocompromised, or, as we have seen before, if the person has very mild of no symptoms, but this is contradictory to the title of the slide, and in that case, the immune response, the humoral immune response, may be delayed. If you have both positive, well, in this case, this is an infection with immunity in development but not resolved. This looks resolved, late stage of infection or previously immune, if diseased with another kind of disease. But since we are dealing with symptomatic or high risk, it would be advisable to check again for RNA. And the same comes if you are dealing with a person that happens to be negative about RNA and serology. The rule of thumb should be this person is naive to the infection, but again, due to the pre-testing probability here and to the environment, it should be better to repeat testing in this scenario. Now, let's consider exactly the same combination in this different scenario in which the population is completely different because it's asymptomatic and at low risk. Of course, the combinations are the same, but in this instance, compared to this instance, okay, the combination is the same, but the population is not. So in this case, it is extremely likely that we have a status of immunity, which does not mean protection. Remember this, please. This is immune response to the infection, does not equal protection or immunity certificate or whatsoever. And again, on the last instance in which both are negative, usually you may deem that this person is naive to the infection. This is not a symptomatic high risk. This is asymptomatic low risk. So even the interpretation of the results of any given combination of assays will depend a lot upon the environment on which testing is taken. Then another possibility is that by any given reason, you just start by serology. This usually cannot be done, of course, to diagnose, but this would be good if you want to do a prevalence study, if you want to ascertain which has been the actual diffusion of the infection in a given population. If you remember the case of the US aircraft carrier, in that case, you have serology first, a double check here, negative, positive, and then what you do next. Again, there is no rule, but you may consider testing for RNA here in order to be sure that the person is not still infected. And if not, of course, this person is immune with the same indication as before, that is immune, whereas the immune response to the infection does not equal protection. If you have a negative and you want to be absolutely sure, just out of precaution, you may retest after a couple of weeks, and if it's still negative, it's a naive. If it comes positive, it could be a window here, and then you may consider testing for RNA. But again, what you do and how you do that depends a lot on the environment, of the eventual recommendation and practices. So this is just, if you wish, something you may discuss with your colleagues and peers. Then what if antibody tests are negative? And this will become more and more frequent the more we go on in testing. The most easy interpretation is that the person is naive to the infection, has not been infected yet, and possibly will never be, hopefully. But you may also have a person that is tested during the very early phases of infection, so antibodies have not been raised yet. We have seen cases in which antibody response is pretty frequent in the early stages, but this is not common, especially if people have very few symptoms. Then you may consider also the fact that many people will encounter the virus and clear the virus just by the innate T-cell response. So in this instance, antibodies will not be raised, and the person will not be detected by simple antibody testing. It encountered the virus, did not get the disease, resolved the infection just by natural immunity. Or, and this will become more and more frequent, the person was infected, had some sort of active infection, so mounted an antibody response, but the levels are constantly or for a long time below the limit of detection of any given assay. Again, it depends so much on the kind of population and then the kind of symptoms, if any, that the person may have. So a word of caution on that. Doesn't matter what you have seen or what you may read on papers that are dealing with severely ill population when you're testing population with less disease severity or no severity at all, it could happen, and there have been reports about people being constantly positive or positive for a long time for RNA without a detectable antibody response. So this is the limitation. And if you wish to conclude, it does not tell 100% that the person is susceptible. So even by the best possible assay for antibodies to SARS-CoV-2, the negative predictive value will never be 100%. But nevertheless, there is utility in testing for antibodies. Since we are targeting the Abbott IgG assay, how may we use that? Well, first of all, an aid in the etiological diagnosis when? On probable cases, so symptoms plus epidemiological or anamnestic evidence, when RNA testing is negative or cannot be performed, and if patients are presenting after 9 to 14 days from the onset, and this is what the CDC has very recently indicated in their interim guidelines. Second, to evaluate the number of people exposed to SARS-CoV-2, and this will be very useful to ascertain the prevalence, and if you wish, also the incidence, because if you take the same cohort and test the cohort over time, and we do know that there are research projects aiming at that, you may find also the new cases that will become positive for antibodies, and this will allow to estimate the incidence. So overall, testing for antibodies by this assay may allow to allocate resources and also to plan for future interventions. That's it for today. Thanks so much for your attention.
Thank you, Dr. Galli, for that informative presentation. We will now start the Q&A portion of the webinar. If you have any questions you'd like to ask, please do so now. Just click on the Ask a Question box located on the far left of your screen, and we'll answer as many questions as we have time for. So let's take a look at our questions coming in right now. Dr. Galli, which role may antibody testing have in the diagnosis of COVID-19 and SARS-CoV-2 infection?
This is a very relevant question. Thank you for posing that. As you know, according to the indication we got from the WHO and the CDC as well, antibody testing can support or aid diagnosis of infection and disease whenever viral RNA yields a negative result or cannot be performed, with the limitation is that sampling occurring before 14 days may limit the validity of serology. On the other side, antibody testing is a classical measure to evaluate prevalence of any given infection, and this has already been considered in some countries when seroprevalence or serosurveillance studies have already been started.
Thank you for that. And why has the Abbott assay not been verified on other coronaviruses different from SARS-CoV-2?
Well, yes, this is a valid question, but at the time of the assay validation, we did not have this capability since such samples are not easily available. Nevertheless, a careful selection of the N-region sequences in our assay resulted in a very good specificity, as we have seen. By the way, 6 independent studies so far have confirmed that there is a lack of cross-reactivity to other coronaviruses, so we are pretty confident about that.
Thank you, Dr. Galli, and I want to thank our audience for these great questions coming in. Dr. Galli, have there been reports of patients who tested negative for IgG antibodies more than 2 weeks after the onset of COVID-19 disease?
Yes, indeed. This has been observed by different independent studies. Part of those cases may be explained by host-related factors, such as a transient or prolonged status of immune deficiency, as an example, transplant recipients. More in general, patients who experience a mild disease have usually later and less sustained antibody response. And finally, you must remember that disease onset is a subjective estimate, and there may be quite a difference between the actual onset and what is reported by any given patient.
Thank you, Dr. Galli. And have there been concerns on a widespread use of antibody testing due to perceived lack in specificity?
Actually, this concern was here initially, due to the relatively poor performance of some assays that we made available soon after the start of the pandemic. None of those, by the way, were on automated platforms such as the one we have described today. The assays on automated platforms, including the one from Abbott, have a much higher specificity, and that shall guarantee, as we have seen, a good positive predictive value, even if the population tested has a low prevalence.
Thank you, Dr. Galli. And we have time for one more question. Why did Abbott choose to develop an assay for IgG instead of an assay for total antibodies?
Good question, thank you. Well, the data available at the time the assay had been developed, and those have been also confirmed later by other studies, including those performed with the Abbott assay, have shown that in this infection, in SARS-CoV-2 infection, the difference in seroconversion between IgG and IgM is minimal. And in many instances, there is no difference at all, or IgG are detectable even earlier than specific IgM. Also, the IgG response is usually looked for in seroprevalence surveys since it lasts longer. By the way, an IgM assay from Abbott will be available a few weeks from now, so being able to discriminate an IgM from an IgG response will allow a better staging of the infection and may be especially useful when RNA testing gives a negative result.
Thank you again, Dr. Galli, for your presentation today. Would you like to provide any closing remarks for our audience today?
I will be delighted to. First of all, I thank again everybody who joined today, and I do hope that this was useful and also will stimulate discussion, because this is a field that is moving so fast, So the knowledge we have reached up to now is not enough, especially on the kinetics and antibodies and the neutralizing response, and we will hope to have further evidences to share with you very soon.
Thank you. And before we go, I want to thank the audience for joining us for today and for their interesting questions. And questions we didn't have time for today, and those submitted during the on-demand period, will be addressed by the speaker via the contact information you provided at the time of registration. And I'd also like to thank you again, Dr. Claudio Galli, for this time today and for your important research. I'd also like to thank LabRoots and our sponsor, Abbott Diagnostics, for underwriting today's educational webcast. This webinar is available for unlimited on-demand viewing through July 6, 2020. Thank you. Bye-bye.